Thank you, Giuliano. Thanks to everybody. It's a pleasure to share with you this opportunity to speak about the different aspects of hepatocellular carcinoma. My topic today is special problems in the modern treatment of hepatocellular carcinoma in cirrhotic patients. And indeed, we are dealing about special populations has been summarized recently in this red published in the Journal of Hepatology by Professor Galler's group. Special population means special problems, and special problems means special management. So our target is definitely optimal care, optimal treatment, and improved outcomes. But to reach these points, we have to keep in mind a number of aspects, such as medical and physical differences between patients, morbidities, competing risk of death, because as Professor Amadori underlined, we are dealing with patients who have two problems, cirrhosis and cancer. We have to keep in mind the problem of access to care, treatment compliance, and potential treatment-related adverse events that are obviously very important for patient survival and for patient quality of life. And we have etiology and underlying biologic differences between patients and tumors. And also these are to be kept in mind. With all of this in mind, the special population are a lot, and I will try to give you an idea of some of them, just touching very, very briefly others, and for some of them I will not talk by any means. So let's start with elderly patients. Elderly patients are a problem. Patients develop hepatocellular carcinoma usually above 60 years of age, and they reach the step of systemic treatment as a mean 5 years later when they are above 65 years of age. So there are a number of studies showing that these patients are characterized by a worse survival, at least in this paper from Japan, with a cutoff, and we have to keep in mind the problem of cutoff, with a cutoff of 75 years. So this paper, as a few others, are suggesting that above this age, the survival of patients treated with a systemic treatment is worse. But not everybody agrees on that. These are data published by Jordi Bruix and Joseph Lovet, deriving from the analysis of 2 phase 3 studies on sorafenib. And as you can see, there is no difference at all in survival, in the hazard ratio for survival in patients above or below 75 years of age. So, as I said, not everybody agree on the point. Again, similar data have been obtained by Evelyn Boucher in study of elderly patients with a slightly lower cutoff of 70 years of age, but again with no difference in progression-free survival or overall survival between patients younger or older than 70. This, despite the fact that these patients had the major bleeding, a trend towards more frequent major bleeding, even though the significant levels were not reached, and a more frequent cessation of treatment due to treatment-related toxicities. These patients were characterized by earlier stopping of the treatment with respect to patients younger than 70 years. With all of this in mind, probably a number of investigators introduced the concept of reduced dose. And both in this study that I'm showing by Kaplan and his co-workers, a reduced dose of sorafenib didn't impact at all on patient survival. And the two survival curves, as you can see, are almost equal. And with respect to adverse events, there was a clear-cut, almost significant reduction of any adverse event and a significant reduction of GI adverse events. These data have been, by the way, verified replicated also in the Sofia study that was carried out in Italy. It was a multi-center, multidisciplinary study and obtained exactly the same results. No difference in survival, even slightly better survival in patients treated with reduced dose sorafenib. What do we know with respect to other drugs? We have few data on lenvatinib. As you can see, with a cutoff of 75 years, there was no difference in survival between patients younger and older than 65, just 75, sorry. And with respect to cabozantinib, patients younger than 65 were characterized by a hazard ratio for death slightly above that of patients younger than 65. So older, sorry, than 65. Though cabozantinib, the results were even different with a better survival in patients older than 65. But the cutoff, as I say, is 10 years younger than for other studies, not on cabozantinib, but on sorafenib. Finally, to go to the immunocheckpoint inhibitors, the data we have available are very, very scanty. We have just a limited number of studies. One is this, reporting a lower incidence of toxicity in elderly patients, but mainly a different profile of adverse events with more frequent skin reaction in older patients and more frequent endocrine adverse events in younger patients. So a different profile of adverse events in patients younger and older than 75 years. Finally, with respect to atezo plus beva, which is going to be the first-line treatment, it is already the first-line treatment in several countries, not in Italy, because in Italy that's still to be approved. But with respect to atezo plus beva, apparently there are no difference at all in response rate and survival in patients younger and older than 75, with a p-value of 1. So absolutely no difference. These results obviously depend on several aspects that I had no time to go into, but probably where you put the elderly bar is probably important, because as you have seen, there are studies with a bar at 75, at 70, or even at 65, and we are talking to a very different situation in my mind. The conclusion of the review I showed you at the beginning of the study with respect to the age cutoff is that probably the doses of sorafenib should be kept lower in patients aged more than 75. But on the other hand, that there is no information at all enabling us to draw any conclusion with respect to other agents such as lenva, cabo, or atezo plus beva. Special population, type 2 BC, sorry, I cannot move this, type 2 BC. This is another important point, because with the getting poorer and poorer of liver function, we have to register a number of adverse events. And the duration of treatment, as we can see in the slide, becomes lower. The share of patients that undergo less than 8 weeks of treatment becomes over 50%, and the share of patients that have a treatment longer than 28 weeks is no more than 10%. So with child B and C patients, there is a clear-cut reduction in the time of exposure to the drug. Sorry. The point is that this is due to developing of a serious adverse events and even of death. The percentage of both events, serious adverse events and death, becoming higher and higher when we move from child A patient to child B, B7, B8, B9, or C. And definitely these serious adverse events are more common and affect patient survival and quality of life too, obviously. The Gideon study showed us that in type 2B patients in the real life, survival obtained is no more than 5 months. And definitely 5 months is not a very large span in the life of the patients, even a patient with cancer. Also because when we examine in the study published in Hepatology a few years ago, survival, the natural history of untreated hepatocellular carcinoma, and we observed the survival of HCC patients who are mostly treated with sorafenib, as in the Gideon study. BCCC patients had a survival, a spontaneous survival of 7 months, which is over what obtained in type 2B patients. So we have to keep in mind that if we obtain something, it's not clear if we do, but if we obtain something, this is very little. And it has to be observed also in terms of cost effectiveness, social and personal cost effectiveness, obviously, for the patients. Other studies on child BC patients show us similar results. You can see this is another study with a survival of 5.9 months in patients with child B situation, with mostly child B7. By the way, the situation is probably worse with child B8 and child B9, with a large share of the patient experiencing adverse events, and in particular liver dysfunction in relation to the advancement of tumor burden. The conclusion of the review, on which I keep going back because it's summarized for other aspects very well the situation. For other aspects, because I don't really agree very much with this conclusion, is that immune checkpoint inhibitors and TKIs can be used with a reasonable degree of caution in patients with type 2B liver functions. Really, I keep it. I think it's very hard to be to agree to very much with this conclusion, because in my mind, the cost effectiveness ratio, as I said, is definitely very, very high. We pay a lot from the social point of view. The patients pay a lot from the personal point of view in terms of adverse events, and the results, the gain obtained is very limited. Obviously, there is no indication in type 2B/C cirrhosis to receive targeted therapies. Another important problem is bleeding. Bleeding has been observed since the pivotal studies of sorafenib, the SHARP trial, with a trend toward an increased risk of bleeding in patients treated with respect to placebo. And this has been observed in several other studies with a trend toward an increased risk with again, a worsening of liver function, type 2A 11%, B 14%, C 21%, and for any bleeding 70% versus 18 versus 23. So there is an increased risk of bleeding, even though the statistically significant levels are not reached in this paper on cancers. It has been discussed whether this increased risk is definitely higher than the spontaneous risk of bleeding in the cirrhosis, because these patients also harbor cirrhosis. As you can see, for any severity of bleeding, the difference is significant. There is a 70% increase in risk of bleeding with respect to cirrhosis in patients with hepatocellular carcinoma treated with sorafenib or other anti-angiogenic therapies. And the risk of severe bleeding does not reach a significant level, as you can see in the slide, but again, sum up to over 70% of increased risk. This led to some contraindications to the use of both atezo plus biva or levantine besorafenib, which should not be used in patients with gastric esophageal varices at high risk of bleeding, not treated with respect to levetiracetam, or in patients who experience recently GI bleeding for both the approach, therapeutic approach. So we have to give a clear-cut caveat with respect to the use of these drugs, whatever drug acting on angiogenesis in patients at risk for bleeding without endoscopic treatment of these viruses. So even Peter Gale maintains the same point that screening for viruses has to be performed by definition in this patient before starting the treatment, even though with respect to atezo plus biva, we have not the data enough to generalize the results in studies carried out with different drugs. Liver organ transplantation was the topic of Professor Van Thiel. I don't know if he will get back to us to speak about this point. I didn't carry with me any slide, but this one that's basically summarize a few other studies saying that immunocheckpoint inhibitors should not be used in patients with prior organ transplantation or uncontrolled pre-existing autoimmune disease. On this, we will get back in a short while for safety concerns with a higher organ rejection rate. And indeed, autoimmune disease are another important scenario. Patients with autoimmune disease have different type and different stages of autoimmune disease. And we have to distinguish, because if we are talking about established, long-lasting, stabilized immune disease, like I would say a thyroid disease or something like that, we should not be too much afraid, but there are other situations in which our caution should be maximal. So we have to be to distinguish, to study the patient and decide on a person-by-person base. There are at present insufficient data to consider a patient with autoimmune hepatitis for treatment with checkpoint inhibitors, because this is a field we have no data enough to draw any conclusion on the point. But in patients with neurological, neuromuscular disorders, autoimmune disorders, in patients with poorly controlled autoimmune disorders that require high doses immunosuppression, TKI should be considered the first choice in this patient, and immunocheckpoint inhibitor should be considered with very much cautiousness. Portal vein thrombosis is another point. We know that patients with portal vein thrombosis are those who respond worse to sorafenib, and this has been shown in several studies in the past. This is probably due to an impairment of liver function, an additional impairment to liver function in patients with portal vein thrombosis. There are no data again to generalize any conclusion because of the heterogeneity of the situation of the patient with portal vein thrombosis. Treatment remains challenging, as summarized by Peter Gale, and we have no data on DEVA plus atezo in this field. We know that for lenvatinib, for instance, patients with portal vein thrombosis, main trunk portal vein thrombosis has not been included in the study, so we cannot use that drug specifically in this kind of patients. HIV, the survival of the HIV affected patient is very poor in any situation. These are data published by our group a couple of years ago. So we have to consider that the series of patients with hepatocellular carcinoma and HIV infections is characterized by very poor survival. And the survival is even poorer probably in patients who undergo sorafenib treatment. This independently of a flare of HIV infection, which does not appear to happen in this patient under treatment, at least with sorafenib. But this is a study where at the end of follow-up, HIV viral load was undetectable in over 90% of the cases. Therefore, it's not a problem of flare of infection, it's a problem of the impairment of liver function that gets worse and worse and impact on patient survival. So at this point, any attempt of treating with either anti-angiogenic drug or immunocheckpoint inhibitors patients with HIV infection should be carried out in a multidisciplinary manner, involving the specialist of HIV related disease in the therapeutic choices for these patients. A few final considerations, a few final caveats. The first one is we are indeed dealing with a limited share of patients, because these are data we have just published in a real life setting. This is the Italica database, and as you can see, the percent of patients on those diagnosed every year that can go to first line atezo plus biva treatment is no more than 6-7%. Slightly higher is the percentage on those who arrive to systemic treatment after previous surgery or after previous local regional treatment. There we are around 30%, but it's quite limited, and this limitation derives from this list of almost endless of situations in which you should not use atezo plus biva. There are a lot, as you see, contraindication to the use of these associations of drugs in these patients with respect to lymphocyte count, platelet counts, or whatever aspect. You see, the list is quite long and limited the number of patients we can consider for this kind of treatment. And in any case, we should balance very well our choices. Here is a list of special situations, but I'm not showing this to go into detail, but just to make you think the fact that for any special situation, we should create in our mind our personal algorithm of choice, whether the patient has pre-existing autoimmune disease, or is child B, or has inflammatory bowel diseases, a topic that I didn't cover at all, or has a NASH related hepatocellular carcinoma. Every patient has to be considered with respect to his situation and to the most intelligent and choice we can do for this patient in kind of tailored algorithm to treatment choice. Also because there are situations we go back with our mind to pre-sorafenib era with all drugs to which we can teach new tricks. And here I like to quote a paper by Giuliano using imatinib, the lower dose in patients with HCC, with some unexpected results in terms of patient survival and response to treatment. And a paper we published a few years ago on capecitabine that used either with a regular schedule or with a metronomic schedule, low dose every day, was linked to a survival around 8 months. That is more than we can expect in a few of the patients we were dealing about before, like for instance, child B patients who have a 5 months survival. So in any case, just to conclude, a figure I'm very much linked to, and is think. We have to choose wisely and think about the patient, his specific scenario, his comorbidities, his life expectancy, his quality of life. Think about. Thank you.
Fabio, thank you very much for this indeed excellent presentation and the different use of the products for cancer. And this gives me my first question, that I think we should use age in a very different way, because age, we have to differentiate between nominal age and biological age. You know? So if we take into account that patients with 60 years are very, very different, and we also can say that we have cofactors which are very important in age, in the discussion of age. That means, for example, diabetes, or vascular disease, or renal insufficiency. So I think the value of comorbidity is much more important than only the nominated age at all. What do you think?
Definitely, this is what I was pointing to with my conclusion. Every patient has to be considered overall, and then you make a choice.
Thank you very much indeed for this very excellent presentation, and it shows how difficult and how differentiated we should look into the problems.